The mental health toll of displacement. When people are forced to flee their homes, the consequences go far beyond physical relocation. Displacement deeply affects every aspect of a refugee's life emotionally, socially, mentally, and economically. This experience, often referred to as invisible suffering, is one of the most underaddressed dimensions of the refugee crisis. The journey into displacement typically begins with violence or persecution. Refugees often witness or directly experience traumatic events such as bombings, torture, ethnic cleansing, sexual violence, or the murder of family members. For example, many Syrians who fled during the civil war have spoken about barrel bombings in civilian areas and mass arrests. Rohingya refugees from Myanmar have shared accounts of sexual violence and systemic state-led attacks on their villages. The trauma does not stop with escape. The flight itself often involves life-threatening conditions, including treacherous crossings through deserts or seas, detention, and exploitation by smugglers or traffickers. Once they reach safety, many refugees are not offered peace, but instead live in precarious or dehumanizing conditions in camps, detention centers, or urban slums, often under hostile political climates. Refugees are at high risk for a range of mental health disorders, especially depression, anxiety, and post-traumatic stress disorder, PTSD. According to the World Health Organization, WHO, 1 in 5 people in conflict-affected populations suffers from a mental health condition. Refugees, especially those in protracted displacement settings, often experience, like chronic grief and loss from separation or death of loved ones. Survivor's guilt, especially among those who escaped while others perished. Trauma reactivation when faced with reminders of past horrors. Hopelessness, especially when asylum claims are delayed or rejected, or when resettlement is not an option. In many camps and host countries, mental health services are grossly underfunded. The UNHCR has noted that mental health support is among the least prioritized aspects of humanitarian assistance. Language barriers, stigma, and a lack of culturally sensitive care further limit access. In recent years, alarming trends in suicide among refugees have been documented, particularly in detention centers or settings with extreme uncertainty. Key examples include Australia's offshore detention system has reported multiple suicides and severe mental health deterioration among asylum seekers held on Manus Island and Nauru. Medicine Sans Frontiers described the mental health of detainees as among the worst they had ever seen, including cases of children as young as 10 attempting suicide. In Greece's Moria camp, a 2020 UN report described mental health conditions as beyond crisis point, with suicide attempts among both adults and children due to overcrowding, violence, and indefinite waiting periods. A 2021 study published in The Lancet found that suicide risk among displaced populations increases significantly when there is long-term uncertainty, lack of access to legal pathways, or separation from family. Although comprehensive global data is limited, the WHO and UNHCR emphasize that suicide and self-harm are growing concerns in protracted displacement settings. Mental health interventions are critically underfunded, receiving less than 1% of total global humanitarian health budgets. Children face unique psychological risks during displacement. Many are exposed to violence, lose years of schooling, or grow up in militarized or highly stressful environments. Studies show high levels of PTSD among refugee children from Syria, South Sudan, and Afghanistan. Common symptoms include nightmares, aggression, withdrawal, and developmental delays. Unaccompanied minors are particularly vulnerable. Many suffer from anxiety and depression, and without parental care, they often lack stable support systems. In the UK, several reports by the Refugee Council and Save the Children highlight how delays in asylum decisions, lack of guardianship, and detention contribute to deteriorating mental health among young asylum seekers. Displacement is not just about movement, it is often about stagnation. Refugees in limbo for months or years without legal status, work rights, or education access experience existential despair. In the UK, for example, asylum seekers are often banned from working and must survive on minimal government allowances. Long waiting times, sometimes exceeding 18 months, can have devastating psychological effects, especially when paired with threats of deportation or poor housing conditions. The European Union's border policies, including the Dublin Regulation, have been criticised for concentrating asylum seekers in frontline countries where resources are limited. Asylum seekers stuck in countries like Greece or Italy for extended periods without clarity face constant fear of rejection or return. Forcibly displaced families are often torn apart. Whether due to chaos during flight, legal restrictions in host countries, or border controls, many refugees remain separated from spouses, children, or parents for years. The psychological toll of prolonged family separation has been documented as a major driver of depression and trauma. In the UK, the restrictive approach to family reunification under immigration rules has faced criticism from NGOs and legal experts. Many refugees are forced to navigate complex legal systems to reunite with family members, often unsuccessfully. This separation is not just an emotional hardship, it leads to mental health deterioration and impacts integration outcomes. Women and girls face disproportionate risks during displacement, particularly gender-based violence, GBV. According to UNHCR, incidents of rape, forced marriage, and exploitation are widespread in many refugee settings. The trauma from GBV, often compounded by cultural taboos around speaking out, leads to depression, suicidal thoughts, and social isolation. Yet, mental health support for female survivors remains scarce. To address the mental health crisis among refugees, both policy and funding priorities must shift. Recommendations from leading humanitarian agencies include integrating mental health into emergency response, psychological first aid, PFA, and trauma-informed care should be standard practice in all refugee operations. Expanding access to community-based mental health services, particularly in host countries with large refugee populations. Training local healthcare providers and involving refugee communities in service delivery to build trust and cultural relevance. Addressing root causes of despair, such as prolonged asylum procedures, employment bans, and family separation, which compound mental health challenges. Fighting stigma and promoting awareness of mental health as a legitimate and critical health issue in both camps and urban settings.